So I've been asked to start the session by setting the scene about how having an ECG management system like MUSE could be beneficial in addressing some of our day-to-day challenges that we face in providing care to our patients in cardiology. At the time of the invitation, we were probably going to get Muse around this time, but actually our Muse go live date is next week. So I will next week become a Muse user. So I look forward to hearing what the others have to say about their experience with Muse. But I will probably set the scene by talking about a bit about the ECG and how we currently potentially struggle with handling the volumes of ECGs and how maybe having an ECG solution like Muse can solve a lot of those problems. And I'd love to come back in a few months' time to update you on how we have managed to use our Muse system to address some of the challenges that I will share with you today. So, the ECG has been around for a very long time, and the very first ECG was actually done at one of the hospitals I work in St. Mary's Hospital. And our department's named after Augustus Waller, who did the first ever ECG. Many of you might not know this fact that it was actually not Eindhoven who did the first ECG, but Augustus Waller. And he had his dog Jimmy here, you can see, standing in pools of saline that were connected to an uh, electrometer that would record any potential difference shown here at the bottom. He had this quite ingenious method of having a toy train that would carry the piece of paper moving around so he could track the changes in electric activity of the heart. Now, we know since then that Eindhoven has developed the ECG machine and made it really, really wide scale and received the Nobel Prize for it. And it is what we know today. We have a regular ECG that looks very much like what Eindhoven had recorded back in over 100 years ago. And in this example, again, this prototype where they had the limbs and the leg in saline, and we can record the potential difference. And from that, we can see so much from the ECG. We can tell whether someone's having myocardial infarction, we can tell about arrhythmias, and now with AI, we can tell so much more from the ECG. ECGs have significantly expanded in use since the days of Waller and also Eindhoven. These are estimated numbers. I'm not sure how people come up with these numbers, but it's estimated about 1 billion ECGs are done every single year worldwide. And in Europe alone, that's 300 million. And in the US, it's 200 million. And this is just ECGs. We're not really counting things like single lead ECGs from smartwatches, which will significantly increase these numbers. So as a result, there is such an opportunity to use ECGs to help us treat our patients on a day-to-day basis. But you might see already the challenges of handling so many ECGs, or having some way of keeping track of the ECGs in a systematic way that allows us to maximize the use of the information. Uh, it's a real challenge with the volume of the ECGs. So, what are the current opportunities for using ECGs, and what are the challenges that arise, and how might having an ECG solution help address some of these things? I wouldn't go into all of these details because I think many of you work in these settings anyway and are very much aware of what is being done regularly for these ECGs. Um, of course, I think we've got to talk on the emergency department later. I go to the A&E quite a lot. We get asked to see patients with arrhythmias or with potential myocardial infarctions. What happens in our hospital is a bit of a mess. We have lots of paper ECGs that are scanned, that are filed away. Some of them are on our system, some of them are lost. And we have a very patchy system at the moment where we cannot track historical ECGs. So we don't know whether if someone comes in with a new left bundle branch block, whether or not that is due to a new change or whether or not something that was there before for the last 10 years. So not having that, I think, misses the potential of using ECGs for the best care that we can provide. So having a systematic way of collecting ECGs, being able to compare to historical ECGs would be very useful. I've just finished an outpatient clinic. I make all kinds of decisions in clinics about whether someone should have a drug or should have ablation. Sometimes they're referred with a so-called arrhythmia like atrial fibrillation. But we don't know what they've had. Sometimes it's not atrial fibrillation, it could be just ectopic beats, and we need to see the ECGs to make the right decisions, to refer for the right operations, right, for the right ablations. At the moment, we do struggle with that because we do not have a systematic way of collecting all the ECGs that allows us to see what the arrhythmia was, what the exact type of arrhythmia, so we can give the exact drug to match that or the right ablation procedure to fix that. So that is a problem, and hopefully we'll fix that once we have our MUSE system live in a week's time. And of course, inpatients is another challenge. A lot of patients on our wards get daily ECGs, but they move from ward to ward. Sometimes the pieces of paper are lost and we don't really keep track of what's been going on. And it's hard to know when someone said, oh, they had a bit of a pause 3 days ago, where the evidence was, and we have to go hunting. And sometimes without that, we struggle to make the right decisions for patients. So having, again, a systematic way of keeping ECGs on the ward will be extremely beneficial for someone who's managing inpatients on a regular basis. So these are things that could potentially be solved with a good, robust ECG solution system. I also want to talk a bit about the future of how we use ECGs because I think some of the inpatient stuff we'll hear later in the session. I want to talk a bit about how we're using ECGs now beyond the conventional setting on the wards in the outpatient clinic and how we might be able to again benefit from the MUSE system in getting us to run these new pathways of treating patients. I want to start by talking a bit about virtual wards. In our hospital, we've been pioneering virtual wards where we treat patients at home rather than in the hospital. So, for example, someone could come in with an atrial fibrillation with a heart rate of 120. In the old days, what we would do is we would have to keep them in hospital for a day or two, do some tests, get the AF to settle down, and then discharge them. A lot of the time, these patients actually feel quite well. They don't feel unwell. They're sitting around waiting for a daily ward round. But the rest of the time, they're walking around not really that symptomatic. There's a real move now to try and get these individuals back home on the day of coming in, but then to monitor them while they're at home. So they're in the ward, but not in the physical ward, they're on the virtual ward. And this is something that I think a lot of hospitals are moving towards. But we are facing challenges, and the challenges really relate to having a robust system of capturing all the information, including ECGs. So the way these virtual wards work includes sending patients home. They're actually all at home, but they have recording of ECGs sent across to the hospital, and we are able to monitor them virtually, remotely, so we can advise on who needs additional treatments and who can stay at home and who can then be discharged from the virtual ward if their heart rate settles. This has become quite a cost-effective way of managing patients, especially in healthcare systems that are struggling for resources, many of those worldwide, including ours on the NHS in the UK. One of the ways is to do a single ECG so they can send across ECGs to us, and then we can have a look at their rhythm. Have they gone back to sinus rhythm? Are they still in AF? If they're still in AF, what's the heart rate? Do they need more medications to try and slow them down going forwards? And you can imagine the amount of ECGs that we're getting at the moment, both from GPs, 12 leads, also single leads, is a bit overwhelming. This massive data deluge that's being created by this whole virtual ward system becomes really unmanageable and becomes very difficult to navigate if you don't have a systematic way of collecting ECGs, storing them, and allowing you to sort of look through historical records. Having said that, a lot of the pilot study shows that this concept is worth doing. You can keep them in the virtual ward, watch them for a few days, give them some medications, let the heart rate settle, and then discharge them. So that's a very good way of managing patients in their own home without keeping them in hospital for days on end at risk of infections and all the other things that you have in hospitals. And here at the hospital, we've also run our own pilot using a combination of ECGs, but also using PPGs to try and watch their heart rate before they get discharged. And there is a traffic light system based on their heart rate. So if they are very fast while they're at home, they can be brought into hospital. If they're in the middle, they get continued monitoring. But if they're in a nice range, they can be discharged and then they're no longer part of the virtual ward. And that appears to be a real way that we're moving towards treating patients now away from the wards in the hospitals. But the challenge is this, the challenge is the data integration. We have now got a system with nurses that can phone patients, check on how they are at home, advise them on the right medications, discharge them when they are well. What we struggle with is really capturing all the information that is being sent through to us at home, both ECGs and single lead ECGs. And there is a very patchy, patchwork way of doing things at the moment. So we are certainly hoping that when we have a central ECG repository, all of these things will get deposited automatically. We'll have to set up some ongoing system that might do that, that will capture all the ECGs, single and 12 ECGs in the same place. So the physician can then manage these patients on the virtual wards a lot better without having to second guess what's going on when they are blind to the information, not seeing the entire picture, not seeing all the information about the ECGs. Similarly, another opportunity with ECGs is now to monitor patients after procedures. And we do send ECG machines out to patients. We send single ECGs that they can send information back to us. I do a lot of AF ablations. And one of the things is how quickly can we pick up the recurrence? How can we affect the treatment pathway for the patients if there is any early recurrence of atrial fibrillation? There's a lot of evidence that if you monitor patients after AF ablation, you pick up recurrences. If you don't see them for 6 months, of course, you don't pick that up. And if you can pick them up early, what you can do is maybe then make a more efficient pathway, send them back to have more ablations, have earlier treatments that could be beneficial for the patients. A lot of this remote monitoring now depends on, again, monitoring patients in their own homes with ECG or single ECGs and having them send that back to us so that we're aware of early recurrences of atrial fibrillation. And in another hospital that I work at, we have this pathway that's been developed where they go on a waiting list, they have the ablation, but instead of them waiting 12 months to see a cardiologist, they can be monitored intermittently through ECGs in their own home, and that can be sent back to us so we can then monitor them early, trigger them through a different pathway if AF recurs. And the pilot studies so far have been encouraging that, but if you do this for the patients, they get earlier interventions, earlier repeat ablations, repeat cardioversions, because we find out about the recurrences a lot earlier. But as I said, the challenges with both these things, both the virtual ward and managing patients on a remote pathway after a procedure, is this problem with the data volume. We end up at a stage where we cannot really reliably manage such large volumes of ECGs that are being sent on a regular basis without a clear system of storing it, archiving it, and labeling it so we know where to find the ECGs in questions. And there are risks. So although we are trying to have these new pathways and new ways of making things better for patients so they can stay at home with their AF, they can get early detection with after a procedure, there are real risks when we have a patchy ECG system that is not systematic, that ECGs are being missed, medical legally, ECGs are being sent in to us and no one's seen it. If there's something wrong with the ECG, whose responsibility is it? Incorrect diagnoses are being made because we're not seeing all the ECGs, so we may think the patient's fine, but there may be some AF recorded at some point that we're not seeing. So although these pathways are useful, they're creative, they actually create a lot more problems if we don't have the basics. We don't have an ECG management system that can help us handle all these large volumes of ECG. So again, we're looking forward to hearing the next speakers and their experience with MUSE, and maybe in 6 months' time, I'll tell you how MUSE would have changed how I manage my patients across these pathways. Two more additional opportunities and challenges about how something like MUSE may solve. One is, as I said, this boom of wearable and portable medical devices and screening in the natural environment. There are all these new devices now that record ECGs, and I know there is a partnership between Cardia and GE MUSE, and AliveCore is one of the first that made a device that can record ECGs and pick up things like atrial fibrillation. And I have a lot of patients now with intermittent arrhythmias where I say, look, I don't really know what's going on, but you go and record your ECGs, and then you can send it to us if you have any symptoms, and then we can look at it, and then we can make a diagnosis rather than putting lots and lots of halters on without seeing anything, because when you put it on, often they don't have any symptoms. Again, that would appear to sound like a very good system, but the problem we face is still the data volume. So if you have some system like this where people are doing a live call recordings and they're recording their ECGs, if you don't have a good way of capturing it and every single patient is emailing these things in to your system, what you get is the risk of having too many ECGs and things being missed and the wrong decisions being made. So having that central repository is very important. But it does work. So if you are able to do this in patients' homes and you record ECGs, it's actually pretty good at picking up things like atrial fibrillation. So we can then start them on the right treatment pathways, like anticoagulation, to get their risk of blood clots and strokes down to a sensible limit. And all of these devices are relatively equal in terms of the ability to pick up these arrhythmias. There's not really much difference between them. They all use a slightly different sensor, but they all work really well. And as I said, a lot of these things do match the cardiologist interpretation. So if you have a device that tells you it's got AF, it almost always matches the cardiologist because it's got a very good algorithm that picks up R interval irregularity. But how do we manage them? How do we store them? How do we capture them? That is a challenge that we are currently dealing with, that we're looking forward to a solution. So just to come back to this screening and detecting ECGs in their own homes, same problem as before, and you're getting a theme now, I think, which is that in any modern system, we do need uh, a way of systematically collecting, storing ECGs. And in this case of intermittent ECGs to try and look for arrhythmias, what I have is my patients randomly emailing a ton of ECGs in. They're not integrated, they're impossible to find. No one knows where they are. They're stuck on someone's inbox somewhere. So some way that can integrate into a ECG system that saves them all, that can be compared to both single lead and 12 lead, would be absolutely needed now that we have this boom in patient wearable devices and this boom in portable medical technology. We need to have that information stored accurately in our electronic health records. And finally, for the last 5 minutes, I'll talk about my pet topic. Every time I speak, I end up talking a bit about AI enhanced ECGs because it's the future. We have had the ECG for about 100 years. And for about 100 years, we've only done one thing. We've looked at the ECG, we tried to work out what's on the ECG, and we've made a diagnosis. But now with AI, there are a lot more opportunities to try and apply fancy tools to pick up things that were never possibly seen on ECGs before. People can use it now to pick up undiagnosed heart failure, undiagnosed valve disease, things that require echocardiograms, for example, can now be done with the ECG. So the ECG is facing a real renaissance in the last few years because of AI. But again, the challenge here is how do we get all these ECGs in one place? How do we get them running on the AI models and retrieving the AI outputs from the ECGs? We need a single centralized system of handling ECGs for that to happen. I will run through a bit of the AI ECG stuff that we've been doing just to show you how this might be useful in the future and how maybe having it on something like MUSE could be useful. So we in my research group have spent a lot of time training different AI models to look at ECGs, to estimate risk of heart problems, and also predict future problems. One of the things we did a few years ago was to train a model using 1.2 million ECGs to try and predict someone's risk of death. So we can take an ECG in, put it in the model, and output the risk of someone dying in the next 10 years or so. And it outputs a single survival curve like this. And it says in this individual, they have a 10% chance of being alive at 3 years, a 50% chance of being alive at 6 months, and 100% chance of being alive on the day of the ECG. What is scary with AI is these things are quite accurate. So you can see these are two individuals with the survival curves, and the predicted time of death actually is very close to the actual time of death. So you can now take ECGs to do superhuman stuff like predicting someone's mortality risk, predicting someone's risk of heart failure, telling you all kinds of things that we might not have previously been able to do. So the opportunity is there. But the challenge is how we apply it, how do we implement it in a system that is centralized, that works. So when we published this, we had quite a lot of press around it. I always show this slide just for a joke because one of the tabloids picked this up and they said we're about to use a superhuman death calculator that would tell everyone when they're going to die. Why would we want to know? Which was quite a funny headline, but not really what the purpose of this tool is. This tool really is a estimator of risk. So what we do is we can do ECGs and do lots of ECGs and see how the risk changes over time. So you can monitor the patient. You can then change the way you prescribe your treatments and test based on some of the outputs the AI is giving you. But again, how do we run it? We can't have every single machine printed out, scanned, and run on the AI. We need a centralized system that can take all ECGs in the hospital, run it on AI models, and instantaneously output the information to the clinician so they can benefit not just from the ECGs being in the same place, but also from all the new AI technology that is coming through that require this centralized system. These AI models are very good in trying to separate out risks, as I said, so it can pick up the highest risk of dying from the lowest risk of dying. And these are 500,000 patients followed up over 20 years. And you can see how good it is in distinguishing the very high from the very low risk individuals. And now, not just us, but everyone else has AI models that can not only predict mortality, but a whole range of different things. Like, do you have heart failure? Will you get complete heart block? Will you have AF in the next 5 years? Will you develop diabetes, kidney disease? All kinds of things that previously not possible can now be done with AI. But what we need is to have the infrastructure to be able to run the AI to output predictions. And again, it does come down to something like the MUSE system that GE have. So the plan is to put all ECGs into an AI platform and then output the predictions all at the same time. And that absolutely requires a central ECG system that can handle large volumes, that can perhaps send it to the cloud to run AI models, and then send back some predictions to the clinician. So that was a bit of an overview. I sort of stuck to a 20-minute timeline, so we have 5 minutes for Q&A. But as the opening speaker who does not have Muse in his hospital yet, but will have it next week, I hope my task was to show you that the ECG is a great technology. It can do all kinds of things in terms of diagnosis and risk prediction. There are lots of new ways now of using the ECG in the next 5, 10 years. Virtual wards, remote monitoring, AI enhanced ECGs, wearable devices, all of those things use ECGs, but all of these things really require a way of storing all the large volumes of ECGs, allow you to compare to historical ECGs, and which is why I'm very keen to hear from our next three speakers about how they use the MUSE system to address some of these challenges that I'm facing on a day-to-day basis in my hospital. So thank you very much. Hopefully that has set the scene about the challenges in using ECGs, and hopefully we can hear next about the potential solutions. Thank you.
Thank you so much, Professor Ng. This is really interesting to hear about the challenges today and clearly what your aim is to solve with implementing MUSE. AI always triggers me at least. So do you use your AI models in a clinical practice right now, or is it mainly on a research? And do you believe that the implementation of MUSE can lead to a faster adoption in clinical practice?
Yeah, so at the moment we don't use it on a daily basis because for two reasons. One, it's a research tool still, so it's not FDA cleared, but others have FDA cleared models, so we will have that in about 12 months or so. But even then, even if it's cleared by FDA and a CE mark, the problem is how do we run it, right? And I think it absolutely needs something like Muse in the background because what you can't do is have every single ECG, the clinician has to then collate it, scan it, send it somewhere, get the output. It needs to be all automated. So absolutely, if you want to adopt AI, then I think you need a centralized ECG system that can capture all of it and then can return the outputs, but also show you how it changes over time and have some sort of comparison about whether your risk of something has gone up compared to last time or not. It's no point running random outputs without knowing how it compares. So I absolutely believe that you need something like Muse in the background running. It's not just the AI, which is why I'm very excited by our hospitals, as you know, obtaining Muse and both of them having them in the next few months.
Sounds good. Any additional questions for Professor Fu? I don't see anything in the Q&A. Don't hesitate to ask any questions and we will come back. There's one question just popping in now. What was the core research question you wanted to answer and why was Muse the right platform for it?
Yeah, so I don't think it's a specific one single research question. What we're very keen is to be able to use ECGs to help clinicians predict risk and diagnose heart diseases that are not previously known. So this is a whole range. And what we want to do is to enable that. And we are actually running a research study at the moment showing that these things can work prospectively. So it's not so much a single question, but more a single mission, which is to enable the ECG to do a lot more for patients and to pick up a lot more undiagnosed disease and allow us to predict future risk of disease.